paraneoplastic syndromes in lung cancer is concerned, there is no lung cancer conference which is completed without this very important syndromes, which is most commonly associated with a lot of malignancies, but most commonly lung cancers. So beginning with the importance of paraneoplastic syndrome, what actually are paraneoplastic syndromes? So paraneoplastic syndromes are a group of clinical signs or symptoms associated with the malignant diseases that are not directly related to the physical effects, that is invasion, ulceration, or obstruction of the primary or due to the metastatic disease. So in simple terms, these conditions arise due to secretion of functional peptides or hormones from the tumor cells, or due to some immune cross reaction between the normal cells and the tumor cells. Now, as far as the practical and the clinical relevance of paraneoplastic syndromes is concerned, we can understand by this slide that these are the most frequently associated with lung cancer. In as far as 8 to 10% of patients of lung cancer, we can, if we see keenly and observe closely, we can observe paraneoplastic syndromes. There is no relation between the severity of symptoms and the size of primary, and they may manifest before diagnosis and thus contribute in early detection, and obviously it will affect the prognosis of the patient in such a case. They may indicate a recurrence also. They may indicate poor prognosis, more specifically the PNS like hypercalcemia, that is the humoral hypercalcemia of malignancy, or hematological syndromes are associated with very poor prognosis in a few months. And they may indicate better prognosis, more specifically the neurological PNSs, which are onconeural antibody related, are associated with better prognosis. So the various paraneoplastic manifestations which have been described in literature are endocrine syndromes, neurological syndromes, dermatological syndromes, rheumatologic syndromes, hematological syndromes, glomerulonephropathy, ophthalmologic syndromes, and coagulopathy. The two most common I must specify are the humoral hypercalcemia of malignancy, most commonly seen in squamous cell carcinoma lung, and syndrome of inappropriate secretion of ADH, and more commonly seen in small cell carcinoma of lung. As far as the paraneoplastic endocrine syndromes, there is a definitive criteria for their diagnosis, and all these criteria are not to be met though. So the first criteria is there should be an abnormal endocrine function without physiological feedback regulation. Important thing is without physiological feedback regulation. There should be absence of metastasis in the respective endocrine gland. There should be a deterioration in the endocrine function with increasing tumor burden, and there should be an improvement in the endocrine function with the treatment of tumor. And although this must be the last one, evidence of presence of hormones in the tumor or hormone synthesis by the tumor may not be seen in all the cases. These are the various paraneoplastic endocrine syndromes enumerated. I'll be discussing only the first three in detail because they are the most common ones. That is the humoral hypercalcemia of malignancy, SIADH, and the Cushing syndrome. Coming to the hypercalcemia in lung cancer, as far as 8 to 12% of all lung cancer patients at some stage of the disease will have hypercalcemia. Most commonly observed in squamous cell lung cancer, in whom the incidence can be up to 23%. Hypercalcemia can be caused by either the paraneoplastic syndrome or osteolytic metastasis. And surprisingly, the paraneoplastic syndrome, that is the humoral hypercalcemia of malignancy, is responsible for up to 46 to 76% of hypercalcemia in lung cancers. Now, there are 4 mechanisms described, but the most common mechanism is secretion of parathormone-related peptide from the tumor. And this HHM, or the humoral hypercalcemia of malignancy, is usually associated with increased tumor burden and associated with a very dismal prognosis and a median survival of only 1 to 3 months. To detect hypercalcemia, we should know the clinical features of hypercalcemia, which can be remembered by this line: bones, stones, groans, and psychic moans. So there can be neuropsychiatric manifestations like fatigue, lethargy, mood changes, in severe cases, cognitive dysfunction and coma. The GI manifestations will be nausea, vomiting, abdomen pains, constipation, and rarely we can have pancreatitis. But if it occurs, it is quite a serious complication. Then renal manifestations include polydipsia, polyuria, nephrolithiasis, and nephrogenic DI. Cardiovascular manifestations include arrhythmia and short QT interval. Now, coming to the humoral hypercalcemia of malignancy, which is basically a diagnosis of exclusion. We should first exclude all other causes like osteolytic metastasis, and then we should diagnose a patient to be having a humoral hypercalcemia of malignancy. For this, obviously, the calcium should be more than 10.5, and it is important to, I would like to stress that it is important to calculate the corrected calcium levels. as per the known formula. We should stratify the patients in mild, moderate, and severe, that is 10 to 12, 12 to 14, and more than 14 milligrams per deciliter values. And we should treat aggressively if it is a moderate hypercalcemia, that is more than 12 with symptoms, or if it is a severe hypercalcemia, that is more than 14 milligrams per deciliter. The treatment of hypercalcemia, or rather any paraneoplastic syndrome, is the first thing is treat the tumor. Then we should do, in hypercalcemia, we should manage by hydration with normal saline. Bisphosphonates are commonly used. The onset of action starts at 2 to 3 days. Nadir is reached at 5th to 7th day, and the effect persists for 3 weeks. And then we use denosumab, the rank ligand antibody, and calcitonin, which has a fairly rapid onset of action, but the effect is temporary and partial. Again, I would like to stress HHN confers a very poor prognosis in patients with the expected survival of just 1 to 3 months. Coming to the most famous paraneoplastic syndrome, that is SIADH. So clinical SIADH occurs in around 7 to 6% of small cell lung cancer cases. 70% of all the paraneoplastic SIADH cases are associated with small cell lung cancer. And it is a state in which the patient is euvolemic, that is, he is not dehydrated, and hypoosmolar, and they have hyponatremia. So it is characterized by low serum osmolality and inappropriately high urine osmolality in absence of diuretic treatment, adrenal insufficiency, heart failure, or cirrhosis. Also, they should not be having decreased sodium intake, which is a fairly common thing observed in our cancer patients. And they should not be we should rule out sodium wasting due to drug-induced nephrotoxicity and IV infusion of hypotonic fluid. This also indicates a poor survival. The symptoms of SIADH to diagnose, the symptoms will depend upon the development speed of hyponatremia and the degree of hyponatremia, obviously. If it is a slow decline in the serum sodium levels, the symptoms are mostly non-specific, and the neurological symptoms are not usually observed. Patient will have vague symptoms of anorexia, nausea, headache, fatigue, and irritability. If the sodium has declined very rapidly or has gone down below 120 milliequivalents per deciliter, then the patients will develop cerebral edema, and they'll have features of headache, restlessness, confusion, coma, seizure, and brainstem herniation, which can be, of course, fatal. Now, to diagnose the SIADH, we have set parameters which should be met before we label a patient as having SIADH. The serum sodium should be less than or equal to 135 milliequivalents per liter. There should be low serum osmolarity, less than 275 milliosmoles per kg. The patient should be in a euvolemic state. The urinary osmolality should be high, more than 300 milliosmoles per kg. The urinary sodium should be more than 20 milliequivalents with normal dietary sodium intake. And of course, we should rule out any thyroid or adrenal or renal failure. Now, the treatment of SIADH is of particular relevance. We should obviously, as other PNSs, we should treat the tumor. The water intake should be preferably restricted less than 1 liter a day. We should always supplement oral salt capsules, extra salt in diet, and we may or may not use diuretics. Now, the use of diuretics is a bit controversial in this one. We can nowadays very commonly we are using tolvaptan, which are ADH-B2 receptor antagonists. We should start off with 15 milligrams per day dose, and then in 21 days we can change the dose to 20 milligrams in a day, and the dose should not exceed more than 60 milligrams per day. And in patients who have hepatic dysfunction, these drugs are to be used with caution. We can also use 3% saline, although this is a very I say it has to be used with a lot of caution. 3% saline in cases where the sodium is less than 120 milliequivalents per deciliter, and the infusion rate should not be more than 1 ml per kg per hour. Obviously, in ICUs or HDUs where we can monitor the infusion rate, because there is a high risk of demyelination, and we should avoid increasing the sodium levels more than 8 to 12 milliequivalents per day. Coming to the ectopic Cushing syndrome, this is also a paraneoplastic endocrine syndrome, most commonly associated with small cell carcinoma lung due to the ectopic secretion of ACTH by the tumor cells. It is seen in around 1.5 to 4.5% cases of small cell carcinoma and indicates a poor prognosis. The important thing is all symptoms of the Cushing syndrome may not be evident in our patients because the prognosis is poor, and because of the aggressive nature of malignancy, these patients may not survive to develop and manifest all these symptoms, which a typical Cushing syndrome patient should have. This is a busy slide, and before labeling a patient is to be having a ectopic Cushing syndrome, we should have at least one of the following which are to be met. At least 2 high readings of 24-hour urinary free cortisol, 2 measurements of late cortisol. There should be a exclusion
Abhishek,
of iatrogenic hypercortisolism.
sorry, you have 2 minutes left.
Yes. So as far as treatment is concerned, again, we should treat the tumor. Various drugs have been used like ketoconazole, metyrapone, and they reduce the cortisol synthesis. Now, the second category of PNS are the hematological PNSs. They are often asymptomatic, typically observed in advanced stages, indicate again a poor prognosis, and treatment is to treat the tumor. Specifically, I'd like to stress upon granulocytosis, which is seen in non-small cell carcinoma lung, more commonly with adeno. In these, the tumors have been found to be secreting GCSF, GM-CSF, or interleukin 6. This confers very poor prognosis of around 1.5 months in patients if granulocytosis is there, and usually it is found in the patients along with hypercalcemia. Surprisingly, these are mature granulocytes, and we might think that there might be an increased risk of vaso-occlusion, but since these are mature granulocytes, there is no increased risk of vaso-occlusion. Another interesting sign or paraneoplastic syndrome is Trossiu's sign of malignancy, which we also know as paraneoplastic coagulopathy. It was described initially in 1865 by Dr. Armand Trossiu, who was a legend in the field of medicine. In 1865, he described unexpected and migratory thrombophlebitis in visceral cancers, and unfortunately found it on himself 2 years later, and he died of gastric cancer. So more commonly seen in adenocarcinoma of lung, and the treatment is by low molecular weight heparins. Vitamin K antagonists are not preferred in these cases. Rivaroxaban can be used as an alternative in such cases. Now, the neurological paraneoplastic syndrome, the only paraneoplastic syndromes which confer a better prognosis. The mechanism is onconeural antibodies and antibodies against tumor with cross-reactivity to neural antigens. In 80% of the cases, the neurological symptoms precede the cancer diagnosis, so they help in early diagnosis. And spontaneous regression of malignancy has also been reported in some case reports in which neurological paraneoplastic syndrome have been observed. They can affect CNS, PNS, neuromuscular junctions, and muscles. And we have to suspect if there's an unexplained acute subacute neurological deficits, especially in old age. And these are the various neurological syndromes. Most commonly, they are associated with small cell malignancies.
I'm sorry, but we will have to end there, please. Please close.
Okay, sir. Okay, yeah. Can I conclude?
Yes, please.
Right. So in conclusion, the timely detection of paraneoplastic syndrome may aid in early diagnosis, early detection of recurrence, and may aid in determining the line of management based on the expected prognosis. The management of PNS may significantly impact the quality of life and also the survival outcomes in our patients. And the elucidation of mechanism of occurrence of these syndromes could lead to possible development of newer therapeutic strategies. So paraneoplastic syndromes are not only theoretical, but hold a very great practical significance as far as lung cancer is concerned. Thank you.